those of you that heard us talk this morning, you're aware that sort of catheter-associated UTI is a particular area of problem area in catheters. And for those of you that were at the workshop in here just before lunch as well, will have heard a bit more about catheters, and those who were at the Convatec workshop as well in the main hall will have heard more. So I'm delighted. There's so much about catheters and the problems and the positives as well to do with them. So it's a double act again. We're going to go backwards and forwards because there's certain bits that are really important that we both sort of cover. Really, the first start is why it matters. And I'm sorry I'm having to look round at that, but I don't have any other screen to remind me what's on the slide. But as has been alluded to by a number of speakers today already, this is a huge global issue. It's not just in the UK. And with the inexorable rise of antimicrobial resistance, it's becoming an alarmingly big problem. It underpins an awful lot of deaths globally, but also in the UK. And to be honest, I think how we record death and how catheter-associated UTI as a causative factor is reported probably means that we underestimate it. So there are an awful lot of elderly patients who are near the end of life, who for one reason or another end up in hospital. So they get pneumonia, they end up in hospital because they are so unwell and they can't mobilise to the loo. They end up with a catheter in, and then they end up with a catheter-associated UTI. And on top of their pneumonia, they get a touch of urosepsis, and unfortunately that's endgame. So I think it's a bigger problem than we actually tell ourselves that it is. Patients with catheter-associated UTI, or Cauti, as I'll call it, they're a very specific patient cohort in terms of UTI. They display a completely different bacterial spectrum to what I would term a simple UTI. So that's a complete misnomer, really, simple. I don't like it, but that's what we all call a simple UTI. So if one of us in this room just happens to get a UTI at some point in our life and we recover well and we never have another one, that's a simple UTI. Cauti, by definition, are complex UTIs because there's a foreign body in the urinary tract. And they do have, because of the different bacterial spectrum that's involved, they often do have higher rates of antimicrobial resistance to antibiotics. So I'm hoping that you have access to these talks after the conference, because a lot of this I'm putting in references so that you can look at your leisure if you want to, and I've referenced the sources for all of this. But there was a really interesting study in 2016, 2017, and it's very difficult getting up-to-date data. As you know, the sort of NHS data always lags about 10 years or so behind, 5 to 10 years behind in terms of getting decent data. But in 2016, 2017, they looked across 153 NHS trusts, and 52,000 inpatients with catheters had Cauti. Now, 38,000 of those were ones which they think arised in hospital, so they were hospital-acquired UTI or HORTI, because their symptoms started at least 48 hours after admission, and about 4,000 were community-onset Cauti. And out of those patients, an estimated 4.8% of those inpatients went on to develop catheter-associated bloodstream infection, bacterial infection bloodstream, or urosepsis as we call it. And as I mentioned this morning, urosepsis is really frightening, and it can escalate very quickly, and people can deteriorate incredibly quickly with it. So that's what we're trying to make sure that our best practice minimises the risk of. So if you minimise the risk of Cauti, you by default minimise the risk of urosepsis. And there were also, out of those patients, there were also some community onset CABCs as well. What's quite sort of alarming, I suppose, in one way, is that CABC was fatal in just short of 1 in 5 patients. And amongst the survivors, around 40% of them developed chronic health conditions because of the fact that they had had that urosepsis episode. So, you know, the last line talks to you about costs, and we all know the financial pressures in the NHS, but for me, the big thing is the personal cost to the patient who's suffering. If you count indirect costs as well as direct hospital costs, the financial burden of Cauti is huge. So it's been estimated to be about 99 million per year to the cost to the NHS, but I think that's an underestimate as well. And, you know, this was the most up-to-date sort of type of costings I could get, and they're already 10 years out of date, so you can only add to these costings. So just a quick recap, we talked about some of these this morning. So patient risk factors, as with any other patient with a UTI, comorbidities and current immune status are really important. It's also important to know whether their sort of perineal catheter hygiene is compromised. So if you've got a patient with a long-term catheter, how good is that hygiene? If they've got fecal incontinence as well, it's a real uphill battle to keep perineal hygiene as good as possible. You know, if any fecal matter gets, you know, when we're not talking visible fecal matter, but microscopic fecal matter gets anywhere near that catheter or tubing or urethral meatus, particularly in a woman, it's going to get into the bladder. And as I mentioned before, any foreign body gets colonised by the bacteria that live on your perineum within a matter of minutes to hours. So catheters are never going to be sterile. So good catheter care is absolutely paramount. You know, I came across a lot of people who automatically say, oh, catheters are bad. Catheters aren't bad, but bad catheter management and bad catheter care is what's bad. It is bad if someone's got a catheter in when they shouldn't have one in and they don't really need it and it's there for convenience for whatever reason and no other options have been tried. But if you know, there are certainly patients out there where there is no other option available and a catheter is the right way forward. If they've had a history of catheter-associated UTIs, especially with an atypical or a multi-drug resistant organism previously, then obviously they're you know, red flag signs here that you've got to have a high index of suspicion for further Cauti and antimicrobial resistance. So quite a few studies have been done, and I've listed them, looking at long-term care facility residents who use catheters, and they have twice the rate of E. coli or Klebsiella UTIs, 4 times the rate of antimicrobial resistant E. coli or Klebsiella UTIs. The presence of an indwelling urinary catheter increases the risks of a UTI by 3 to 8% per day, and I think one of the speakers already today has mentioned that. And a survey of 425 care homes in the UK found that just shy of 7% of the resident population had a urinary catheter. They didn't expand on reasons as to why that urinary catheter is in, so out of those we don't really know whether they were necessary or whether it was just that's what they arrived with, so they've carried on with it. So other risk points to consider. Remember that urosepsis CABC is a potential killer at any age and any fitness, and an obstructed infected urinary system is a surgical emergency. So for those of you who work in secondary care, that it's really important to know that. But I would also say that septicemia and urosepsis is greatest at the point of intervention. So that's either when you're first putting a catheter into someone, or you're having to deal with a blocked catheter, maybe flush it, trying to get it running again, or that blocked catheter is being changed, or you're removing a catheter. So those are the times where you get a bacterial shower that can then enter the bloodstream. So, you know, it's a nightmare if you get someone who's arrived and, you know, with blocked catheter and people have tried, you know, they've come in and they've had like 5 changes in 24 hours and you're just like, oh, you know, because they are so prone to urosepsis in that situation. And prolonged catheterization is the most important risk factor for Cauti. I'm going to hand over to Helen on this one and get her to speak a bit further.
Thanks, Mary. Thanks, everyone. So yes, catheter care is essential. We've mentioned that if it has to be there, then looking after it the best we can is obviously what we should try to do. And we've spoken about just using them when they're appropriate. I mean, there's lots of incidences where patients could self-catheterize. We know that this leads to a big reduction in UTIs. And where patients can't do it themselves, carers can be taught how to do intermittent catheterization and protect the patient from having an indwelling catheter. It's not for everybody, but even to consider patients whose condition may improve over time, where they could move on to that. And of course, the use of catheter valves to maintain catheter bladder capacity is also essential if you can, with a thought towards moving towards self-catheterization. So in terms of the actual system, there's some audits that have been done. What tends to happen is that where we all fall down is in using the link system. So it could be that the nurses on the ward or in the community or whatever may not have the correct equipment to hand. Maybe they haven't got access to the products that they need, or there's some confusion around attaching the night drainage bag direct to the catheter inlet, and rather than attaching the night bag to the outlet of the catheter and then just discarding on a daily basis. Whenever they've done spot checks on the ward, they have actually found that this is confusing for a lot of people. And if we consider on the wards, a lot of the catheter care is undertaken by students, healthcare assistants. They need to sort of have very clear guidelines on how to manage the system, empower the patients. They know exactly what they're doing when they get home. And that also leads me to another point, which is to make sure on discharge, if they're going home from hospital, that they have all the equipment they need to be able to effectively manage the catheter with the family, with the carer, or themselves. And they have ongoing supplies, that the communication has been sent to the community teams, that the patient has a telephone number to ring if there's a blockage, usually on a bank holiday or a Good Friday or whatever, usually at the wrong time, but that patients know exactly what to do if there's a problem with the catheter, so they're not left floundering and turning up at A&E, which is not what we want. So numbers are very important, and ongoing supplies. I mean, I used to work in the community, and the amount of times I used to find little old men with the catheters attached to their thighs with sleek tape or sellotape. So it's definitely something to think about. Planning and ongoing supplies are very important. Yep, and the catheter specimen of urine, of course, it's becoming more widely appreciated that if we were to take a sample from any catheter, 9 times out of 10, 99% of the time, you're going to show up bacteriuria. So obviously, we're just taking samples if the patient is clinically unwell. The other thing that I'd like to sort of quickly touch on is correct fitment of the catheter, because if we know that if it's under trauma, if it's under tension, it's going to cause damage to the urethra. Has anybody ever seen where the catheter's fully eroded through the urethra and actually caused a complete, I'm not going to be like Elliot and show horrible pictures, but you can know, for those of you that have seen it, it's terrible. And of course, in those cases, suprapubic catheterization, sometimes urethral reconstruction. And then your ladies who bypass, or a larger and larger catheter is put in to try and manage that. And actually all that's happening is you're making the urethra bigger and bigger and bigger. And it's just a vicious cycle. So it's having the correct product. What catheter does the patient need? Not just what's on your cupboard in the shelf, but the length of it, the Charrier size, smallest to do the job, all of these things. And then again, what springs to mind for me is an elderly lady who perhaps has a long catheter bag and you can see it poking out the bottom of her trousers when it could be fitted discreetly at a higher level, or even there's thigh bags available. So I think, if you're as a health professional, I think we need to know what products are out there, and if the ones we have are not fit for purpose, and to individualise that care. Use of G-straps, don't leave them flapping in the breeze. All of these things can lead to blockage infection, and it just perpetuates the problem. So just to sort of think about that, really. And a clear plan, is it in temporarily? Is there a date to come out? Make sure the patient knows to query it. I thought this was coming out. I need this appointment, so that we are advocating for the patient as well. And we've already touched on alternatives, haven't we? So I think back to Mary to look at what's been done.
Thanks, Helen. So I'm going to whiz through the next lot of slides, but it was sort of, a question was posed to us about whether it was time for a national campaign on catheter care, and should the Urology Foundation spearhead a national campaign. So it got me into looking at what's already been done, and actually there's been an awful lot of national campaigns, but the trouble is a lot of them have fallen by the wayside, as these things do tend to. So I'm just going to whiz through the 4 nations really to show you what's been done. So there was in 2018 there was a bit of work that came out of Newcastle with NHS England, led by Jackie Rees, who's a nurse consultant up in Newcastle, called the part of the Atlas of Shared Learning, and it was a case study. And it was sort of, the tagline was no catheter associated urinary tract infection. So no catheter, no Cauti was their sort of strapline. And one of the main take-homes from that was that it's great having advice, but if you don't share it with others and you don't communicate it, then it doesn't get very far. And they advocated that people start small in your local area, in what you're doing, your job, and then do collaborative working, constant monitoring, and have enthusiasm to embrace high standards of clinical practice to achieve effective patient outcomes, because otherwise campaigns just won't work if we don't follow it through. NHS England also launched a campaign to help reduce hospital admissions for UTIs back in 2023. And I've put these up so that you can look them up yourself as well, to have a look in them. But basically they acknowledge that UTIs are a leading cause of life-threatening E. coli bloodstream infections, and that if left untreated, they can lead to severe infection, sepsis and death, potentially. So England have also done other things. So there is available, Public Health England did their own thing, the ENACT study, and exploring the implementation of inventions to reduce antibiotic use for patients with catheters. The NIHR, the Institute for Health and Care Research, did a health technology assessment and looked at strategies for older people living in care homes to prevent UTIs, and that was, their strapline was the Stop UTI realist synthesis. NHS England also did excellence in continence care, and that was a practical guidance for commissioners, leaders, and leaders in health and social care. So England has done quite a lot. Wales has also done quite a lot. So the Public Health Wales had this 1,000 Lives project that's been ongoing for quite some time. So this headline is from 2013, and that was efforts to reduce the use of catheters and cannulas are paying off. So they'd put in this programme as part of the 1,000 Lives public health initiative back in 2008, and then in 2013 they were reporting that it was starting to reduce the incidence, and that was their Stop campaign. Scotland have had the SUTIN programme, the Scottish Urinary Tract Infection Programme, and they've also, that was from 2023, but previously they've had the Prevention of Catheter-Associated, or Cautis, UTIs, driver diagram and change package. So lots of things have been happening over the sort of last couple of decades in Scotland. And in Northern Ireland, GPs were collaborating to improve UTIs and antimicrobial stewardship in nursing homes. That was back in 2020. So they've been looking at it and working on it as well. In terms of what's practical use out there, there are guidelines available, but you sort of have to go hunting for them. Lots of localities have their own local guidelines. Lots of hospital trusts have their own trust guidelines. It would be lovely if we could just have them all matched up so there was just one clear, simple national guideline, but I think that's in my dreams. But you can get practical guidance from the Royal College of Nursing, from the British Association of Urological Surgeons, from the NHS Infection Prevention Control website, and also the Improving Device-Related Infection Prevention Practice, or the DRIP, which is a great acronym, isn't it? DRIP for urinary catheters, but that was also covering intravascular devices. It wasn't just urinary catheters. On the DRIP website, they do have some really nice downloadable fact sheets and information leaflets if you're interested in having a look at those. And the NHS England have these urinary catheter tools as well. They're like credit card size things that patients can keep in their wallets. So I've shown you the front and back of, like the catheter, their sort of idea of a catheter passport, but it's just in a credit card size, and things to look out for if you're worried about infections. So given that we're right next door to the National Motorcycle Museum, those of you who are bikers in the audience, and I put my hand up to say I used to ride motorbikes, will be aware of the Think Bike, Think Biker national campaign that was around, has been around for quite some time. So I sort of stole the logo and changed it to Think Catheter, Think Cauti. I thought that was quite appropriate given we're next door to the museum. So is it time for another national campaign? Well, we still have a major problem with Cauti. I think what would be more ideal is if we could somehow marry up all the good work that's being done in all the 4 nations and sort of bring it under one umbrella and make sure that rather than just a soundbite campaign, it actually is a practical tool and increased standards of care for patients and actually gets utilised and kept on going. So I'm going to briefly hand back to Helen just for a couple of minutes to just talk about the salient points of the UTI Information Service. She did mention it again this morning, and then the last 5 minutes we'll take Q&A.
Thanks, Mary. Yes, so some of you might have seen this before. It's quite a new service. Would be really delighted to hear from any of you what sort of resources you would like to see for yourselves. I mean, a lot of the stuff we have are for patients and their carers to understand signs and symptoms, how to manage their infections across the counter, self-help strategies they can use, also empowering them to have conversations with their GPs about, being referred on, because there are specialist UTI clinics out there which are springing up quite a lot across the country. And once they're there, they have access to more specialised care, such as, I'm thinking people with chronic UTIs who have gone through hell for years can have access to having antibiotic instilled in their bladder, like gentamicin. They learn how to self-catheterize and put in an antibiotic solution into their bladders, which has the advantage that it doesn't get absorbed systemically, and there's your AMR problem sorted for that group of patients, perhaps, but there is a study going on at the moment comparing that with a daily antibiotic. So it's clear from what I'm hearing that patients will go to their GP. Sometimes they're told that there's no infection when they clearly have one, which is very demoralising. It's usually women, but some men as well. And also, that feeling of being fobbed off, this is what I'm hearing, and the frustration from that. And also, it's not clear whether they should have a 3-day course, which works for quite a lot of people, hence the ability to get that from your local pharmacy, but doesn't work for all women. the symptoms come back, what do they do? Do they need 7 days? Do they need 10 days? Have they ever got rid of the first one? And we're getting to know a little bit more about the bladder biome and what we might not be picking up on testing. So there's a lot to learn, there's a lot to look at in research. The Urology Foundation backs a lot of research, little studies into these things. So, definitely check out the website. Have a little look. If you have anybody, either yourself or a colleague or family members or patients where you're struggling, by all means let them, get in touch. There's an email service and the helpline is open twice a week. As I say, we're developing teaching aids, infographics to be able to sort of understand the clear strategies. Have you tried this? Obviously, drinking water as a first, are you wiping from front to back? All the usual suspects, but then to get into what actually works, what can you do to help yourself? And of course, we're starting the webinars, so it'd be lovely to see some of you there. I think we've really just, get in touch. That's how you get in touch.
That's great.
And there we go.
Yeah.
And we're 30 years old.
Yes, we aren't 30, unfortunately. But the Urology Foundation is 30 years old this year. So it's our 30th anniversary year.